care planning approach is being widely adopted in diabetes, with a number of different models and approaches being developed across the UK. This brief talk gives an overview of care planning in diabetes and how it can be used with older people who have diabetes. Care planning has been defined as a process which offers people with diabetes active involvement in deciding, agreeing, and owning how their diabetes is managed. Care planning is a facilitative approach through which the person actively engages with their own healthcare needs. Key principles for care planning include negotiation and joint decision making, patient-centeredness, developing a partnership with the patient, balancing the clinician's knowledge on disease and pathology with the patient's individual experience, developing an ongoing two-way communication, and being transparent and explicit about the care process. Care planning is part of patient education and self-care support and involves the application of adult learning principles, i.e. learning by doing, learning from mistakes, and building self-efficacy. Therefore, effective care planning demands a high level of consultation skills in eliciting care needs and in building patient confidence and competence. The care plan needs to be straightforward, doable, well-resourced, with appropriate information and therapy to support it, and clear to all those involved in delivering the care plan, including the patient. Care planning is an ongoing process and should be subject to regular review. Applying these general care planning principles to older people with diabetes can be more challenging. While many older people will be able to engage actively in their care planning process, there will be others for whom this may be more difficult. Patients with high levels of frailty, both mental and physical, and those with multiple comorbidities may need a more expansive model of care planning that engages with the patient's wider network of support. Where there is frailty, it would be necessary to include any carers or significant others who are involved in supporting the daily life of the older person. Within the care planning model, additionally, where there are multiple comorbidities and agencies involved, it may be important to designate a care manager to support the care planning process with the older person and their carers. However, this does not negate the importance of building the patient's experience into the care planning. Finally, there may be additional factors that may impede the patient's capacity to participate in the care planning process: visual impairment, physical disability, cognitive impairment, and low levels of health literacy. These difficulties require an approach that is flexible so that an individual can, as far as possible, be involved in shaping their care. Equally, where the care experience is largely determined by others, such as care home staff, the principles of care planning should be extended to include them, in the hope that if they invested the finding solutions for the older person, they would be more likely to implement those solutions with the patient. A number of different models for care planning have been developed. These models generally follow a process similar to that outlined by the NHS Modernisation Initiative, which is comprised as follows. System entry. Clearly, patients can only benefit from a care planning if they are included. Therefore, the care system needs to be designed so that patients can be identified and admitted to the care planning process. Assessment. The process begins with a holistic assessment, exploring a wide range of different domains, including psychosocial and biomedical factors. The assessment should be based on an agreement between the person and professional as to what the assessment and care planning process is meant to achieve. The important outcomes. The assessment should elicit needs and risks. One method used to conduct this form of assessment is to get the patient to tell their story around their diabetes. What's new, what's good, what's tough. This is followed by the professional's story of diabetes. The professional story relays potential issues, evidence, and experience from the clinical point of view. Developing the care plan following the assessment, the person and the professional develop an action plan, both for the person, the self-care element, and the health service providers, the delivery of care. This care planning requires a skilled practitioner who can elicit needs and recognise clinical issues. It is also important that the care planning is undertaken with access to up-to-date evidence and information, including a directory of potential local resources. The care planning should be jointly constructed, understood, and physically held or accessed by all parties involved in supporting the care plan. This, of course, includes the patient. The format of the care plan is important in that it needs to be simple and clearly understood, integrating actions and outcomes. Reviewing the care plan. It is important that care plans are reviewed regularly to help ensure that they are developed and adjusted and updated depending on whether care objectives are fulfilled. System exit. Once patients have achieved their goals and have mastered the targeted self-care behaviours, they may exit the cycle or start again with new goals. Communication. As has been emphasised, care planning is about developing a partnership with the patient. This demands a facilitative model of communication rather than didactic advice giving. The communication should encourage the patient to identify realistic goals and supply the solutions themselves. The professional should resist giving advice and wait for patients to ask for advice or offer advice by permission. This model is summarised by the acronym EP. First elicit from the patient, the E, and then provide advice when the patient requests it, the P. In relation to older people, there are a number of additional factors that should be considered in following this process of care planning. The need to identify the patient's level of frailty and capacity for self-care. If there are deficits in the capacity of the individual to undertake the care planning process, then it's important to consider their wider supportive network. There may be a need to introduce preliminary care measures, including social care providers, to enable the care planning process to be commenced. The need to involve, where appropriate, significant others when an individual's self-care is reliant on or delivered by others. They too must be involved in the process. The need for a multidisciplinary approach. In cases of frailty or multiple comorbidities, the diabetes care element may need to be integrated into a wider context of care delivery. This should ideally involve discussions with all the other caregivers, with care planning being coordinated by a case manager. The need to balance clinical outcomes with the patient's quality of life, maximising function and safety. The care planning model places the patient's needs in the context of the individual's life. Therefore, while in diabetes care planning discussions are centred or referenced around clinical objectives, they must also attend to the care of the individual. This is particularly important in regard to older people whose perspective and priorities for life may be different from those of the younger adult. The older person may privilege comfort, relief of symptoms, and the ability to do the things they enjoy. It is also important to minimise harm and risk to older people, and there are some emerging evidence that being too aggressive in diabetes care can be hazardous for older people. Therefore, while we should seek to avoid complications in older people, the range of outcomes to be addressed may need to be broader, considering other factors such as symptom alleviation, foot health, good nutrition, avoidance of hypoglycemia, and avoidance of hospital admissions. Care planning is becoming increasingly important in chronic disease management to develop and support effective self-care. Older people and those who support the care of the individual should be encouraged to identify what is important to them and make decisions about their own care. Effective care planning demands a supportive, facilitative, and motivational model of communication. Care planning requires a good flow of information between the patient and the professional. Care planning is an ongoing process, and it is important that progress is reappraised regularly, with additional education being provided to support the patient. Older people need different models of care planning depending on their level of frailty and self-care capacity. The objectives of care planning for older people should include a balance of outcomes, including quality of life, maximising function, promoting safety and symptom alleviation, in addition to established metabolic targets.